our favorite segment, the amazing,
great,
and amusing. Yeah, sorry. Pick yourselves up. I don't know what to do.
Oh, man.
Welcome once again to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who is confused by the latest health study as I am by who the hosts of this show are. So we have, as announced on, maybe it wasn't our last episode, maybe it was 2 episodes, we announced that Don would be coming back part-time as a host of the show. Chris Gill is here with us as always. Hello, Chris.
Hey, Matt. How are you?
Doing well, but we have a new host of the podcast who is going to be trading off places with Don, and that is Dr. Jessica Liebler. Welcome, Jessica.
Thank you, Matt and Chris. So nice to be joining you.
So great to have you with us, Jess.
Thanks.
And we are so happy that you are here from the Department of Environmental Health here at the BU School of Public Health. And as a reminder to all of our listeners, if you could be so kind as to head over to the iTunes or Stitcher or whatever podcast app you use, and you could give us a rating, we would very much appreciate it. We'd also love it if you check out the Population Health Exchange website at www.pophealthex.org, where you can go for learning lifelong tools from the BU School of Public Health. That's BU's hub for lifelong learning. It's Population Health Exchange. So now on to the show. So today, in our first segment, which is our Journal Club segment, we're going to look at a study on the effectiveness, or maybe lack thereof, of probiotics, something that I know Chris takes every day. In the second part of the podcast, which is our deep dive, we'll talk about a paper on cognitive biases in a pandemic. And then in our...
I just wanted to mention that probiotics are biotics that have lost their amateur status.
So they've gone professional, which means they can no longer compete in the Olympics.
That's correct.
They used to be JV biotics.
Right.
JV.
Right. They've made it to the varsity squad.
Right, unless headed by Michael Jordan.
Right.
Okay. I think we have officially demonstrated our lack of understanding of sports.
I think Michael Jordan, too. That demonstrates our age, I think, more than anything.
Sorry, who's Michael Jordan? I know who LeBron James is, but Michael Jordan, never heard of him. So then in our Amazing and Amusing, we will get into some things that make us laugh out loud, or we will find out whether Jessica's an amazing or an amusing type. So
The mystery builds.
The mystery builds. So in segment 1, we're going to talk about an article that looked at the impact of probiotics in care home residents. This one was published in JAMA, and the study was entitled Effect of Probiotic Use on Antibiotic Administration Among Care Home Residents, a Randomized Clinical Trial, by first author Christopher Butler of the Nuffield Department of Primary Care Health Sciences at the University of Oxford. I didn't see a lot of headlines for this one, so I'll give you the one that I found, which was from the 2-Minute Medicine. Don't know what that is, but the 2-Minute Medicine, call it a online news service, who says daily oral probiotic combination not effective at reducing antibiotic use for all-cause infection among care home residents. So that is all I've got on that. Jessica, if you could start off by telling us what the study was about, and what they did and what they found.
Sure. I think it's hard for research studies to get too much airtime in this time of COVID anyway. So I have a feeling that if this one came out at a different moment in time, it might have been a little more newsworthy. I agree with you. It didn't get a huge amount of coverage. So anyway, as Matt was saying, this was a study that was in the UK looking at the effect of probiotic administration, a daily oral probiotic combination, on antibiotic usage among people living in nursing homes, among older adults living in, they call them care homes in the UK. And as we know, probiotics, just as a bit of background on why this study might have been done or why it was done, probiotics are widely used to support GI health and to prevent infections, and studies on pediatric populations have shown some promise in reducing incidence of diarrhea or reducing need for antibiotics. However, although probiotics are consumed widely by people across the spectrum spectrum in our population, there's really limited evidence that they have the intended effect across the board. And so this group, they were looking, as I said, whether daily oral probiotic combination of two commonly used probiotics. The first is Lactobacillus rhamnosus GG. So this, just as, again, by a little means of background, this is a bacteria that is often, although perhaps transiently, found in the gut in a normal circumstance. It's considered commensal bacteria, or the friendly bacteria, compared to the pathogenic bacteria that may cause disease. It produces the enzyme lactase in the gut, so it breaks down sugar lactose to lactic acid. And it is widely used, for those of you who have purchased over-the-counter products like Culturelle, the kind of digestive probiotic supplements that you can buy at the drugstore. This is this Lactobacillus rhamnosus GG. That's the core component of that sort of over-the-counter medication. It is used to treat, they call it dysbiotic bacterial overgrowth. So dysbiotic means kind of as a basis of disruption of the normal gut biota. And it's believed, as I said, to be transient in the gut and not permanent, binds to the gut mucosa. And it's also a component of many yogurts, cheeses, and supplements. So it's in quite a number of foods and consumer products already. The second probiotic that they used is another one. And so you will learn over my time in this podcast, I do not do great at pronouncing these long medical words. So you have to give me some.
Welcome to the club.
All right, here we go. Bifidobacterium animalis, subspecies Lactis bb12. So this was the second, the mouthful. The second probiotic that they used in this study. This one also is a constituent of the normal gut microbiota of the intestinal tract, although again does not seem to be a permanent or resident species. It seems to be somewhat transient. And this is the component that's used in those specialty yogurts, for example, like Activa or the Dannon products that are advertised to have a probiotic component. And it's used for treating GI symptoms like IBS or constipation. And this one generally lives in the colon. Okay, so these are just in terms of the two probiotics that were a part of this study. Those are the two. This study is called, they gave it a pretty awesome acronym, I thought, although unrelated to probiotics. It's called the PRINCESS trial, the probiotics to reduce infections in care home residents. As I said, it's based in the UK. There were 310 participants, and it's a placebo-controlled, randomized clinical trial, a multi-center trial, and double-blinded. Okay, the study took place between 2016 and 2018. The eligibility criteria for the participants are 65 and up, living in a nursing home, and people were excluded if they were immunocompromised or already taking in an ongoing way some probiotic formulation. Okay, so the primary outcome, they had a primary outcome and then a large series of secondary outcomes, and we'll discuss how, if large was too many secondary outcomes, but we'll discuss that a little later. Their primary outcomes was the total number of systemic antibiotic administration days over the total number of days the participant was observed in the study. Okay, so they're looking at, basically the research question they're looking at is whether the people who were dosed with these two probiotics experienced fewer days of systemic antibiotic administration during the 1-year study period compared to the people who were dosed with placebo. Okay, so days of systemic antibiotic administration, the core outcome. The secondary outcome, they looked at a series of secondary outcomes looking specifically at what was the health outcome that was linked to antibiotic administration. So total number of days of antibiotic administration specifically by different sorts of infection categories over their participant days. So some of the infection categories they looked at were UTIs, were gastrointestinal infections, were respiratory tract infections, and then they further distinguished between upper and lower respiratory tract infections. They looked at SSTIs, skin and soft tissue infections, unexplained fever, diarrhea, antibiotic-associated diarrhea, Clostridium difficile, C. diff incidence. And then they also used a bunch of quality of life metrics to see if the probiotic administration was associated with quality of life or well-being metrics. They used 2 validated scales in this population of older people. They also looked at pathogens in the stool. which was an interesting analysis that we can talk about, including the 2 species of bacteria that some of the participants were dosed with the probiotics, and then the number and duration of hospital stays and deaths. So they had a whole slew of secondary outcomes within their 310 study participants. And so what happened in this study is study team nurses made weekly visits to each of the care centers and recorded all kinds of weekly data for the study participants, including the amount of probiotics that was given and the amount of placebo, signs of infection, use of antibiotics, any kind of reported diarrhea, hospitalization, adverse events. And they also had, one of the benefits of this study was that they have a tremendous amount of dietary data, medical data on people who were living in nursing homes. Their every move in a good nursing home should be categorized and denoted in their medical record. So there should be a lot of fairly high quality data on exposures, on health, on outcomes, on food, and on all sorts of other things regarding these participants. So then the study nurses collected medical data from the patient's daily record. They administered here's a couple health utility scales, the Euro-Qual Group 5 Dimension Self-Report, the EQ5D, and they also administered the ICE-POP capability measure, which is the Older People Wellbeing Questionnaire. I enjoyed that, those two names.
I like the ice pop.
Yeah, ice pop. It's like, a chill. So they collected these measures at baseline 3 months and 12 months. And they also collected stool and saliva samples from the participants at baseline, 3 months and 12 months. Okay. So jumping into that's kind of the overall picture of their design. Jumping into the analysis, they used 2-level negative binomial regression, accounting for participants nested within the nursing home. So that was kind of the level of nesting. They also used similar Poisson regressions, also with kind of a 2-level structure. They did note in their section on statistical analysis that because of the sheer number of secondary outcomes, the analyses for these secondary outcomes should be considered exploratory because of multiple comparison problems, and they did not do any adjusting for multiple comparison problems. Okay. So for the 12-month study period, at the end of the 12-month study period, we'll jump into some results. About 63% of the participants were alive, and I don't have a good sense as to whether or not that's good or not on the basis of nursing home populations, but I don't know, it seemed okay to me. And so as it related to their core research question, looking at whether the probiotic versus placebo was related to different number of days of systemic antibiotic treatment, they did not find a difference between the probiotic group and the placebo group. So in the probiotic group, over the study period, they had the mean antibiotic administered days was 12.9, so a little less than 13 days of antibiotic use in the probiotic group during the study period, and the confidence interval ranged from 0 to 18, a little more than 18 days. For the placebo group, it was 12 days, with the confidence interval, 95% confidence interval, ranging from 0 days to about 17 days. Okay, the mean difference in antibiotic days was 0.9 days, so a little bit less than 1 day. With that confidence interval obviously crossing 0, so -3 days and a little bit, going up to about 5 days, and their adjusted incidence rate ratio was 1.3, okay? And again, with the confidence interval 0.08 to kind of 1.6, okay? In looking at their secondary outcomes, they noted a few things that are worth mentioning. First of all, they noted more lower respiratory tract infections among the probiotic group compared to the placebo group. And this was a statistically significant finding at the 5% level. So the incidence rate ratio was 1.4. Okay, and 1.1 to 1.9 was the confidence interval there. So, a surprise, the probiotic group seemed to have more lower respiratory tract infections than the placebo group. They also found longer duration of infection for those who had, this is a mouthful, longer duration of infection for those with more than one systemic infection among participants in the placebo group compared to in the probiotic group compared to the placebo group, but the effect was very small, with the incidence rate ratio being just 0.1. Okay, and they didn't find other differences in the treatment and the placebo group by infectious disease outcomes, by hospitalization or death. But they did find too that those who had taken the probiotics had more cumulative days of diarrhea, unfortunately, but that was not a significant difference. But it was 6.8 days versus 4.4 days. You could argue to an individual, that might be significant, 2 extra days of diarrhea. The probiotic group had a lower well-being score at the 3-month follow-up, but not at baseline or 12 months. And so the authors didn't really jump into that finding as too important. What was very interesting to me in looking at this, one of their findings too is, as I mentioned earlier, they look to analyze stool for the probiotic bacteria that they were dosing the treatment group with. And so as they looked in the stool samples at baseline, they found these probiotics in both groups, in both arms of the study. And that's probably to be expected, given that at times these are natural constituents in the gut microbiome. In fact, though, what was interesting is that more of the stool samples from the placebo group seemed to grow the bifidobacterium compared to the probiotic group, and also 25% of the placebo participants provided stool samples that grew lactobacillus, which was one of the 2 probiotics as well. Probiotic group had more samples that grew C. diff, and it's, and the authors note, and we note too, that these are very small counts here. So in terms of, determining whether or not these levels are important, that's a separate question. But it does speak to the possibility that the delineation of the treatment was not pure, so to speak, that the placebo group also was exposed either exogenously or endogenously to the very probiotics that were part of this study, that were part of the treatment. And so the authors touched on that, although maybe not as much as I would have asked them to. So in any event, I think we could certainly jump in and talk about it. It's definitely an interesting study. I think there's some things they could have done to speak a little bit more to the microbiome and things that they could have done to speak more to their underlying biological argument as to why oral consumption of probiotics would affect systemic infection that would be treated by antibiotics, and kind of what is the biology there beyond kind of GI conditions. So anyway, I will let all of you jump in. That's the background.
All right. So overall, you'd say that a randomized trial showing no benefit to probiotics. Chris, what do you think? Are you going to sell your stock in probiotic companies now?
Well, if I had any disposable income that would allow me to have bought stock in anything, maybe I would have spent it on something else. I have to confess that I'm not terribly surprised by the results of this study, and I say that with acknowledging that I have been very long a skeptic of the probiotic field, and my skepticism kind of rested on a few points. One is that many or most of the studies that I've read in the past on probiotics did not seem to be terribly well designed, so that they were vulnerable to selection and ascertainment bias or other biases. And so I wasn't terribly persuaded by the results when they were positive, and a good many of them are negative. So it's really reassuring to me to see like what I see here is a very meticulously done, carefully done, randomized, blinded, double-blinded, controlled placebo trial with meticulous attention to all these different outcomes, which acknowledging that there's a couple of suggestive, sort of tantalizing hints that maybe there was an adverse effect related to probiotics. Overall, I'd say that the result was a complete wash. That it didn't seem that probiotics did anything. And the second sort of source of my skepticism is that I can't sort of figure out mechanistically and biologically or immunologically why it should work in the first place.
Right.
And as you point out, Jessica, both of these bacteria are normal constituents of the healthy gut. So I don't quite understand why, what the theory is behind how adding them in when they are obviously being exposed regularly from the environment, why that would make any difference. And I don't get that. And it's also sort of coming on the heels of quite a lot of interesting research in the last 5 to 10 years about the microbiome of the intestine, which has turned out to be extraordinarily complicated, an ecosystem with all sorts of reciprocal loops of interaction between literally thousands and thousands of different bacterial species and yeasts, as well as parasites. And it is a complex ecosystem. And so one would sort of wondered, well, heck, why would throwing one particular bacterium into the middle of that have much of an outcome on anything when the whole thing is so complex. It just seems like you're asking a lot of this one intervention. And so to see it come back as like, in a very carefully studied way that there is really no impact whatsoever does not surprise me, but actually confirms all my prior skepticisms.
Yeah, I have to say I share some of your skepticism going into it. And I do want to talk at some point about the impact that some of the prior trial work might have had on the feelings about whether or not this was going to work a priori. But I'm interested to know whether or not, if we were to play devil's advocate and take the other side, is it possible that this is not a large trial? So there was what, about 300 odd people in the study. It's just one study, and maybe it's the wrong population. Maybe these patients were too old to benefit from probiotics. Jess, what would you say to that?
It's a good question. I mean, I think my understanding, and Chris, I know Chris has also been engaged in some of these studies on the microbiome, that the gut microbiome is fairly stable in adult life, with the exception of times of illness. And it's even unclear if kind of dietary studies, and some that I have read have been quite dramatic in terms of doing a case crossover study where you're changing people's diets from, say, a totally meat diet to a totally plant-based diet, and then doing microbiota evaluations that actually very little changes in adults on the basis of these different exposures. And my understanding in children is that the gut microbiota is a little more changeable in younger children. And some of the studies that have been done, I mean, I know, my pediatrician, for example, often tells me to go out and get my kids this cultural product to treat diarrhea. And so many of the existing studies have been done in children. However, I mean, this is clearly the population at risk for severe systemic infections. Populations in nursing homes take vast amounts of antibiotics, experience antibiotic-resistant infections at very high levels. And there's a lot of meticulous data that's collected on them, or that can be collected on them, in using the right group of collaborators. And so it's a logical population to study this question, but my sense of the literature is that the microbiota doesn't always change that much from these dietary exposure studies. But I agree with Chris that kind of the underlying biological argument here is not super clear to me. Mm-hmm. I think the idea that even if you're dosing something in the gut microbiome, that you would expect some gut-related changes seems more logical than like a skin and soft tissue infection, for example. I mean, Chris is absolutely right that has been an explosion of microbiome-related research in the last 10 to 15 years, and it does seem to be, some of it seems like the microbiome controls everything, but I think you have to have a pretty specific argument. I think also, when you make these changes, you can potentially cause, they call it dysbiosis in the microbiome, which doesn't always have positive outcomes, even if you are, there's competition within the bacterial species in the gut microbiome. And you add one, it affects the balance of whatever is going on in there. And that balance likely varies somewhat among individuals. And so there's also an argument that it could have a negative impact as potentially well as a positive one.
That's right. It's sort of the absence of a really compelling biological theory for why a single organism, unless it's like highly pathogenic and has some potent toxin, for example, that's going to really disrupt the function or the composition of the gut, or triggers a syndrome that leads to clinicians to dose the patient with antibiotics, which is obviously going to have a profound effect on the microbiome of the gut. So absent those two things, like adding two relatively neutral bacteria, I'm not going to call them pathogens, but two neutral bacteria to this complex ecological web of interactions, I don't see why that should make a difference. And I also wanted to follow up on the theory that you had, and I also shared, that if you were going to see some effect, I would expect to have seen that in gut health, or like incidences of diarrhea, for example, during that year. But that's not what they saw. The only real possible effect they saw was on lower respiratory tract infections, which I have to say makes no sense whatsoever, because the respiratory tract and the gut are not connected, at least not directly in the way that, there may be some common exposure up at the, in the nasopharynx that leads to contact with both, but it's not the same, and so I'm very puzzled about why that alone would be the main apparent effect, which was, of course, worth noting again, an apparent harm of the probiotic. Though my inclination is to not believe that either. It's just being a fortuitous
I was
result.
Gonna say, I have thoughts on that too, which is that I think really when you're talking about the number of secondary outcomes that they had, just doesn't surprise me that something randomly comes up, and I wouldn't put too much stock in that at all. To me, it really does seem to me largely to be a negative trial, negative in the sense of didn't really find any effect of the probiotic, positive or negative on really anything. I do want to just, before we wrap up, touch on just some of the issues with the quality of the study, because generally it seems to me like this was a pretty well-designed study. As we said, it did probably have too many outcomes to be able to really support being able to say anything much about the secondary outcomes, but strongly designed for the primary outcome. But the one thing that does trouble me a bit, and I can't think of any reason why this would change the results, but I think it's worth mentioning, is the issue we talked about in Jess's intro, which is the death. That so many people died in the study, of course, for the obvious reason that this is a much older population in which you expect a lot of death. But because so many people died, it does obscure the ability to actually detect whether or not there is something going on. And I could see an argument for all of that mortality leading to bias towards the null, so that if they were an effect, small effect, you might in fact miss it. I don't know whether or not, there are approaches that you can use to deal with that kind of stuff, like competing risks analysis that wasn't used in this, but I also personally don't always know what a competing risks analysis does in terms of interpretation of the results. So, I don't want to paint that as being an overly important problem, but it does seem to me worth noting. Jess, any sort of study design issues or other concerns that you want to raise?
I would note one more thing in looking at their enrollment flow chart. I think in addition to the fact that it seems many enrolled people died, they had a lot of people who were excluded, who were recruited and then not enrolled. And they were not as specific as I would have wanted to see, kind of as to why. So just looking at it, about 1,300 people were evaluated for eligibility, and 999 people were excluded from the study for various factors. And they go through a number of them. But
excluded prior to randomization?
It's excluded prior to randomization, yes. And then of that group, about half of them, 475, they said were excluded for other reasons, quote unquote. If you could see I'm doing air quote, if you could see my finger, quote for, other reasons. And they don't give why half of their population of people who were excluded, like what were those reasons? Were those people, potentially systematically different than the 300 who were enrolled? And so I think that was I definitely picked up on that as well, that it was kind of unclear why many participants were not enrolled in the end.
Yeah, and I would say that's not you're not worried there about bias in the study so much as they're more about the generalizability of the findings and whether or not, if you were a skeptic of the results, whether or not they, specifically chose a population in which this was destined not to work. I don't really have any reason to think that would be the case, but obviously I agree with you. You want to better understand why it is that they excluded those people. Mm-hmm. Chris, any last thoughts from you?
A very short one, which I'm sort of curious to hear how you guys thought about this question. But, the primary endpoint was, the cumulative days of antibiotic use, systemic antibiotic use over the period of follow-up. Now, it's a funny endpoint because it's not really aligned with any specific disease syndrome. So they're sort of treating probiotics in a sense as some sort of non-specific health tonic.
Yeah.
And I was like, well, that's kind of weird. But then it occurred to me that isn't that actually how probiotics are basically marketed, as a non-specific health tonic? So in fact, this is aligned with how, health supplement manufacturers are pitching this stuff to clients. And so I was wondering how you guys felt about that.
Yeah, I did also, have the same reaction as to it seemed like a strange endpoint to me, and something maybe more specific might, if there was anything going on, you'd be more likely to pick it up. But I didn't get the sense there was anything else going on. Jess, what's your reaction on that?
Yeah, I mean, I think that was one of the strengths of this study, actually, was kind of using things that people are already using in the ways that people probably use them to try to determine if there is an effect. I mean, I think in terms of the microbiological construct of this study, it would have been awesome for them to also do microbiome profiling.
Yeah.
Which could have accompanied, right, they could have done it at baseline and they could have done it at 12 months or whenever the last follow-up was with the given participant to really show if these drugs were affecting the microbiome. And then did it change? Maybe it didn't change at all, or did it change? And then could you really make a case that something was or was not connected? So that was, but in the absence of an effect, maybe that's not as necessary. But I think it would have been neat. I did appreciate also that they are studying people who live in nursing homes right at baseline. I mean, we talk about that now so much with COVID, but it's hard to remember that before COVID, there was very little attention given to people in nursing homes and to research conducted on these populations. And so the fact that they even chose this as a high-risk population, and this was before COVID, I appreciated the attention to this age group.
So true. Yep.
Yeah.
So the one last thing I wanted to raise was this issue of all of the many outcomes that they had. And I'm curious, I mean, I think I've said on this program before that I'm not interested in this idea of adjustments for multiple comparisons, in the sense that you're not going to convince me by doing I was going to say fancy statistical adjustment, but it's not that fancy at all. Most of them are really just dividing up your alpha. You're not going to convince me that something is more important just because, you had a very, very low p-value. But I do pay a lot of attention when there are a lot of outcomes. I get kind of dismissive of almost all of them. And I'm curious whether you all have the same reactions or you like these multiple comparison adjustments. Chris, do you put any stock in them?
No, I don't think so. I mean, I was reminded by a paper I read a couple of years ago where someone had done a whole series of blood tests looking for, some effect of some drug. I mean, the details almost don't matter. And what they had found is that there was some change in the patient's hematocrit indicating that they these individuals were getting more anemic, had shown up as a signal. And though we don't love p-values, the p-value was quite small. I don't remember what it was. Doesn't matter. The p-value was quite small. But the authors said in their discussion that they were discounting it because they used the Tukey correction or something. And I was sort of, a little bit outraged by this because it seemed like, wait a minute, you have gone into this study looking to see if there are physiological, biological harms of this agent, and you have found one, and you are now discounting it based on some arbitrary statistical test. And I thought that was actually totally missing the point of this.
Yep.
So I don't know. I guess I'm with you.
Fair enough. Okay, so I think we're all in kind of agreement that we don't see much going on here. We end up in the anti-probiotic camp, I guess. But for those of you who have your probiotic hate mail, you can send those to Chris, and I'm sure he'll happily take those. All right, so let's...
My email address is mfox@bu.edu.
By the way, can I just ask, so Jess, you mentioned that they use the BB12 probiotic or something like that. Is that related to BB8 from Star Wars?
I think it might be. I think so. It might be. It must be, right? It came from a galaxy far away.
50% better.
I assume so. All right, so let's move on to our second segment where we're going to talk about a viewpoint article that was published in JAMA. It was entitled Cognitive Bias and Public Health Policy During the COVID-19 Pandemic. It was by first author Scott Halpern. And I got to tell you, I love this paper. Not that it was in and of itself brilliant, but it sort of reminded me of some things that I think we tend to forget about in public health. So they start off talking about the fact that we spent a huge amount of money in the early days of the pandemic investing money in ventilators to try and keep people alive. And there was a lot of controversy about how many ventilators we needed. And, the truth of the matter is that most people who end up on a ventilator are already in bad shape. Not that we don't want to have ventilators, but at that point, the mortality is already very high. And so the decision to allocate resources towards building more ventilators and getting more ventilators comes at a cost of the other things that we could do. And yet, when you looked around, people were very supportive of the idea of building more ventilators. And, this article essentially goes into the idea that we have these biases when it comes to trying to evaluate the decisions that are available to us. They exist in our lives, but they become very visible when there are public health decisions that need to be made. And these are sort of errors in human cognition. Errors probably should go in air quotes. They exist for a reason, but they lead to some very predictable sources of bias. So the three that they talk about in this are the identifiable victim effect, present bias, and omission bias. So the identifiable victim effect is the idea that we as people tend to respond more aggressively to threats to identifiable lives. In other words, those that an individual can easily imagine being their own or belonging to people they care about, other than hidden statistical deaths that are reported in population. So we react to things that we can understand as happening potentially to us, rather than just sort of reacting to the large numbers that we see in the statistics. The second one is present bias, in which people tend to prefer immediate benefits over larger benefits that would accrue in the future. So we're much more willing to act on the fear of potential deaths from coronavirus that happen now than the potential results that could happen due to the actions that we take to coronavirus in the future, which may in fact be larger. And then the final one is omission bias, which is the tendency to prefer a harm occur by failure to take action that is a direct consequence of the actions that we take. So we don't want to be responsible for the results of our decisions causing harm, and therefore we would rather take no action if it's going to lead to harm than take action that is going to lead to harm. And these lead to kind of predictable problems in the way that we decide what we do about a problem like coronavirus. And I have certainly seen this in my own my own thinking about coronavirus. And so I wanted to get your thoughts on this. I don't have any specific questions so much as, do you see these things as being very real in your own processes of trying to decide what we should value and what we should be doing about coronavirus? Chris, what's your sense on these?
Well, I guess the first bias, what do they call it? The
identifiable
victim bias. It can also be called the Joseph Stalin bias, right? Because wasn't Stalin the fellow who popularized the expression, the death of one person is a tragedy, but the death of a million is a statistic?
Yep.
Which is sort of ironic coming from Stalin.
Yep.
So I guess that's true, but I also sort of felt like this paper in general suffered from like the 2020 vision or the Saturday, the Monday night quarterback bias.
Yeah.
Hindsight is 2020.
Hindsight is 2020, exactly. So, here we are criticizing the decision to fret about ventilator supply. But I think that's a little bit of an oversimplification. First of all, at the time, we did not know that ventilators would be so relatively ineffective at saving people's lives. And so at the time, it seemed like this is a perfectly reasonable thing to do. Now we know that most people who end up on a ventilator, who die on a ventilator, do so because we are unable to turn off the replication of the SARS-2 virus. And so the ventilator doesn't solve that problem. If you can't suppress viral replication, the ventilator does not help. So you need a drug that actually will do that, and then the ventilator could buy you critical time. So I think that argument to me felt a tiny little bit disingenuous, because it's arguing now that had we known what we know then, we would have favored other things. Possibly true, but we didn't know it. So at the time, it felt to me like it was a crisis. The second thing is that it kind of assumes that the role of sort of macro policy decision making is in the hands of the individual clinicians who are making decisions about like whether to put a patient on a ventilator. And that's not how doctors are trained. That's not how I was trained as a physician. My job was to assess the problem and to try to provide the most effective solution that I had to that problem. And if that was a ventilator, I would have used it. And I wouldn't be thinking about, triage of ventilators until the situation became so extreme where you really are running out of ventilators. And perhaps that happened in New York City to some degree, but it didn't happen elsewhere. And so we never actually came to that point where we had to make triage decisions about ventilators. And so I sort of feel like this is an argument about whether physicians should be physicians and do what they're trained to do, which I think is, of course, we should. So
maybe
I didn't buy that argument somehow.
Yeah, no, and maybe I wonder if you're interpreting it that way because you are in fact a clinician, whereas, and I everything you say sounds totally right to me, but I wonder whether we think about this as not a clinician who's actually the one providing the care, but as the individual who's just thinking about what should I be supportive of, or a policymaker who's trying to decide what to do, whether that might play more of a role.
Right. So that gives me to my third point, which is that they are essentially presenting this as a false dichotomy, in my view, a false choice, like ventilators versus other policies we could have invented. But we now know, and this I apologize to the listeners who really think our president has done a wonderful job, but I personally do not think the president has done a wonderful job. And I feel like we are looking back at these decisions as if somehow we had to choose either ventilators or sensible, mask wearing and social spacing advocacy. We could easily have done both, but we didn't. Right? We had a complete sort of failure of leadership at the national level around critical policies that could have been made that could have turned this into an epidemic that looked more like South Korea instead of more like Italy. But we didn't. We ignored all the evidence in front of us and stuck our heads in the sand like ostriches, and now we are in a disastrous situation. I don't think it was really about, president-patient bias. I think it was about public policy abrogation of responsibility.
I hear you, and I do think that there's absolutely something to that. I do think, though, when I think about my own way of viewing these different policy options that we had, I think that my ability to want us to react in a way that deals with the most salient problem, most present problem to us right now, which is we have a lot of coronavirus circulating and we have to do something about it, and not think about the consequences of what that might do in terms of, lockdowns have consequences that can be negative as well as positive. And I do think that I think more about the immediate versus the what could happen when we act. Jess, what's your sense on these? Do any of these ring true for you?
Yeah, I actually, there was a line towards the end of this article that I'm going to read that I think is very interesting. It says, COVID-19 could provide the impetus for greater ascendancy of public health ethics over clinical ethics. And to me, that was the take-home punch of this article, was that, as Chris was saying, clinical ethics are derived in certain ways, are made in conjunction with clinical colleagues, are made at the bedside. And what these authors are arguing for is that public health ethics should be distinct, right? And they should be distinct and they should be separated from these biases, and that there is a role for public health to elevate over these over these biases and over our human inclinations to value, individuals over statistics or whatever it might be, and that this is a role specifically for public health. And they talk about messaging, kind of how did we flub the message, or why was the message flubbed in the United States? Like there was, in the early parts of the pandemic, there was, everyone was trying to flatten the curve. And that, that draws on this importance of statistical lives. It requires someone to appreciate that under the curve, those are actual individuals, not statistical individuals, but those are real people kind of under the curve. And when you flatten the curve, it means that fewer of them get sick and die. And so they suggest, instead of saying flattening the curve, we could have said something like, the lives you save could include your own, or, something like that, or that of your family, to try to kind of, bring home who exactly we are talking about. And so there was this, I thought there was an interesting value in this discussion of how do you message these big public health interventions in a way that resonate most with people. And, kind of identifying, now, and we're quarterbacking on Monday morning, obviously, that flatten the curve, it worked in some populations and not in other groups. It didn't have as much of a resonance in some communities and it did in others. And so what are different ways that we could message kind of public health interventions that kind of play into these biases that people have, was kind of one. So I had kind of three thoughts. The first was this distinction between clinical ethics and public health ethics, and how are they distinct? And is this really kind of the ascendancy of public health ethics over what the individual doctor might do at the bedside? The second has to do with messaging. And the third was a concern that I had on this piece was, I do feel concerned, and this comes in part just talking to members of my family who don't live in the Northeast, where public health, the image of public health is losing in some communities. And we are not viewed very highly. We are viewed as being responsible for the worst problems that are going on right now in many parts of the country. And so to the idea that public health, it felt a little like trickery to me, like kind of saying, how can you trick people into following along with what we need them to do? It was my concern was that, this sort of thing, it puts public health maybe further at odds if you say go against people's natural inclinations, message in a way that feeds into these biases. Mm-hmm. So I'm not sure if that exactly made sense, but that was something that just kind of rang through.
I totally agree with everything you said, Jess, and I love the way you put it too. And it just makes me feel so sad, because we as a nation have faced, existential crises in the past. I mean, if you sort of think about World War II, right? I feel like, it's called the greatest generation, not because, just because they won the war, but because there was this palpable sense of shared sacrifice and a common interest, and everybody came together. And so there was it's not that politics went away, but politics took a backseat to the need for the nation to come together, for us all to focus on this one critical goal that actually affected our very survivals. And we are not being attacked militarily right now, but our economy has been utterly destroyed by this and need not have been. And people's lives, 158,000 as of this morning, have died in the United States. They need not have been. This was not an inevitable consequence of the COVID-19. To pretend that we were powerless in this is just disingenuous. And so I sort of feel like, yes, there was a complete failure on messaging, but the failure came because not just that the messages were occasionally wrong, like don't wear masks, that was clearly a mistake, but also because the political leadership in this country has systematically undermined or failed to support the public health messaging out of political expediency. And that, to me, that feels like almost a crime.
So are you saying that politics overwhelms any of these biases such that, we really couldn't, if we can't solve the political problem, we can't solve the cognitive bias problem?
I guess that's right, because I appreciate the author's perspective on this. It's very thoughtful, and I don't disagree with the specifics necessarily, but I don't see that these are really the main, roots of our problem. I think the roots of our problem were political leadership. And in a sense, this article somewhat argues that there's a choice between the two, and I don't think there's really a choice. I think you can have both. So I don't know. It makes me feel a little bit cynical and depressed.
All right. Well, we will leave you in a cynical and depressed state as we move on to our favorite segment, the amazing,
great,
and amusing. Yeah. Sorry. Pick yourselves up. I don't know what to do.
Oh, man.
So I'm gonna go first, and I'm gonna keep mine short, even though it's got there's a lot to it. But this is an article that I don't know. It's certainly not amusing. It's not amazing either. It's more depressing. That's why I thought I'd go first this time to just keep it going on. But did you guys see this article? It's entitled "Quantifying Professionalism in Peer Review" by Travis Gerwing.
No. Sounds intriguing, though.
Yeah, this is. I just want to make clear from the beginning that while I normally go amusing, this is not amusing. So this was an article in which they were able to get reviewer comments from the field of ecology and evolution as well as behavioral medicine. And they got a little over, just under 1,500 sets of reviewer comments. They also did some case studies where they actually interviewed people, and they got the reviewer comments through this, I believe it's through Publons, but not 100% sure off the top of my head. And then they went through and they coded them for, comments that they considered to be professional or unprofessional. They were not just looking at professionalism, so they were also looking at instances of questionable research practices, unhelpful comments, things where they just sort of say, you're missing literature, but you don't actually say what the literature is, or comments that were superficial. But I think, clearly based on the title, what they were most impressed by was the negative comments. And
negative in what sense, Matt?
Unprofessional.
Uh-huh.
So let me give you some examples. So what they found was that overall 12% of the comment sets included at least one unprofessional comment. And I overstated things a little bit because when they actually looked at what they're actually looking at in the reviews, there were only 179 of them. So, but 12% of those 179 had at least one unprofessional comment. I can go further on
Can you give an example or two?
Yeah. So I will give you two. So one would be only the meagerest of efforts was required to see the value or lack thereof of this work.
It's not very kind.
Or utterly disappointed in the submission. It achieves nothing and was a waste of funding.
That doesn't sound very kind either.
It doesn't sound very kind, and it doesn't actually sound like it in any way helpful or what we want to be, I think, as a discipline, as academics. It is true. You read things that you do feel this way about sometimes, but it does nothing other than, make you feel good, I suppose, to really say something nasty like this or to say nasty things.
And nasty is distinct from saying, I really disagreed. I felt that the paper was unpersuasive for the following reasons, and I would not recommend its publication because I think it's wrong.
And even better if you can offer constructive criticism that would help ultimately try to get this to a point where you could agree with it. But to just sort of say, things like this, I just don't get it. There is a Twitter website handle, but I can't remember which one it was anymore, that you could put inappropriate things that were said to you by reviewers, and you read those and it's just depressing. So I thought it's worth highlighting this to say that hopefully we are not the kind of people who would say things like this in our reviews, and hopefully our listeners are not as well. Really think about the people on the other end of those reviews, even though it's anonymous. Those are real people who are getting those reviews, and saying unprofessional things really doesn't help.
Yeah,
especially for junior people early in their career, and for doctoral students and postdocs. And I always feel like that's tragic too, when people get those really negative, mean responses really early in their career, and then it can really affect your sense of self for quite a number of years professionally.
Absolutely.
Yeah.
All right, Jess, what do you got for us?
Sure. All right. Here's a question I know you've always been wondering about. What is the biological function of male facial hair?
I feel like it's got to be to make us more attractive.
That very well could be, especially now in the pandemic. I feel like everyone on Zoom is sporting some facial hair. So.
I can't see Chris's current bearded state. Chris, where are you?
Yeah, I'm her suit these days. Her suit.
So there are three of us on this call. Three men on this call, and we all are bearded.
Yeah.
So this is very appropriate. So this was a paper that was published in a journal called, it's a biology journal. All right, a biology journal that I'll give you the title: Impact Protection Potential of Mammalian Hair, Testing the Pugilism Hypothesis for the Evolution of Facial Hair. So basically what the authors are suggesting in this biology journal is that the role of male facial hair was to absorb punches. So that the furrier your face was, the more likely you were able to sustain a facial beating from another male person.
Aren't there people who have those annoying, sort of artsy, hipster, facial hair that just makes you want to punch them?
Maybe yes. They weren't looking at it as the rationale for the aggressive behavior, but it's interesting. So they talk through how when people fight, they tend to punch people in the face, and this was like the root of their core hypothesis that maybe the mandible, they say, when superficially covered by the beard, is the most commonly fractured facial bone in interpersonal violence, and so they hypothesize that the beards protect the skin and bones when men fight by absorbing and dispersing the energy of a blunt impact. So what they did, they did an experiment, okay? They made a fiber epoxy composite as like a bone, analog, and then covered it, okay, in 3 different formats. Okay, one that was covered with skin that had thick hair, the furry model. Okay, skin that had no hair, the sheared or the plucked model, and then they did a sheared one and then a plucked one. Okay, so they had 3 variants of this facial this facial model. Okay, and then they used they call it a drop weight impact tester affixed with a loaded cell and they basically punched it and went to see how much force it could absorb. Okay, and so they took this model, they punched it over and over at different velocities, and then went to see and then looked to see what happened. And they had 20 punches stages in each, the furry, the plucked, and the sheared condition. And they found that it was true that the fully furry samples were capable of absorbing more energy than the plucked and the sheared samples. Okay,
Wow.
And it was statistically significant in their analysis. And anyway, so this supports the hypothesis.
Wow.
They claim that human beards protect the vulnerable regions of the face
Well, what
from
about
damaging
goatees?
blows.
What about what, Chris?
Goatees.
Go,
Yeah.
but punch to the mouth only.
Because I think you'd also have to look at the probability of being punched score as well as the impact of punch.
Yeah, I don't know. And also, like, there's, people get punched in the nose a lot, too, but I don't know if that's, like, nostril hair.
Oh, yeah, good point.
Is explaining that.
Ooh,
right.
that
the
totally
nose
makes sense.
beard. We need a nose beard.
Right. So anyway, a little intriguing scientific tidbit.
Now I know I have this beard.
Right.
All right,
Stay safe.
Chris.
Stay safe.
Stay safe out there. Chris, what do you got for us?
Well, I had actually planned on this is ironic coincidence, on talking about this paper I read in some obscure journal that since I'm not really going to talk about it, doesn't really matter. But it was looking at the amount of Guinness beer that is captured in people's mustaches. Over I think they tried to model it across Ireland or something, and they worked out that something like close to 500,000 pounds of sterling, like money, of beer was wasted because of the amount that gets trapped in your mustache over time. But the more I thought about it, I didn't really think that this argument made sense, because you do kind of lick your mustache, so don't you recover some of that? So I thought their methodology was weak. They didn't factor in the recovery, the mustache recovery, the slurping of your mustache.
Okay, I don't know what you do with your mustache, but
It's just
anyway.
lost to the wind.
Anyway, so I decided not to talk about that, and instead I'd gone to the beach yesterday with my daughter and my wife, and we had a lovely day at the beach. We went to Cranes Beach, and one of the questions that came up as we were driving up is whether there are lots of great white sharks in the water. Because if you guys have the Sharktivity app loaded on your phone, you will know
should I get it?
that thing. You should get it if you want something else to be really anxious about. I would advocate to increase your anxiety quotient significantly, because the alert goes off constantly now. And there was one day, like a week ago on the Cape, I think it was August 6th. In fact, I'm certain it was August 6th, where I counted 26 great white shark sightings off the coast of Cape Cod.
Wow.
Yeah.
Separate sharks,
and
not
just
the
like
same
boom,
guy.
boom, boom, boom.
Yeah.
So you really start to think like, wow, I think I don't actually want to go swimming off the outer Cape or inner Cape, as it turned out, or much of Martha's Vineyard anymore. It just seems like this giant killer fish anyway. So with that in mind, I was primed to respond to this study that was in PNAS, as I often choose articles from, called "Humans Navigate with Stereo Olfaction" by a Chinese group headed by Yuli Wu in the Institute of Psychology and the Chinese Academy of Sciences. And it links back to the sharks, because as you probably know, sharks and dogs have stereoscopic olfactory sense, which means that they can follow a scent based on the gradient of odors between the left and right nostril. And sharks, of course, are really good at this, and this is how they navigate towards their prey. When someone's bleeding in the water, they feel it. It's not just that they're sort of swimming up the concentration gradient. They can actually tell that the concentration is higher on the right side or the left side and turn in that direction. And dogs do the same thing. And if you've ever seen a dog like chasing a scent in a field, you know that they do it. They're constantly kind of scanning left and right and then making these turns. And so the question was, like, is this ability to smell things in stereo true just of certain animals? Is that apparently also true, by the way, in moles and in rats? Who knew? But they wanted to know, is it true in humans? And it is.
Oh
my gosh, it was. And they did this in this sort of like a cute and clever way, where they had people initially looking at a television screen with all these sort of dots blowing at them, like as if it seemed like going through warp space in Star Wars, when they pull the lever and the Millennium Falcon goes off into the distance and all the stars are flying by. So
you can make the Kessel Run in under 12 parsecs?
Right, I always figured that was like a distance, right? It sounds like there should be a time, but it turns out it is a distance. Anyway.
Yeah.
So, they are looking at this Zoop screen, and they, meanwhile, they have inserted this sort of experimental apparatus with 2 straws up their nostrils.
Right up the nose.
And they can then project scents up the left and the right nostril separately at different concentrations. And they had to sort of say, do you think I'm going to the right or going to the left. And then they would kind of like move to the right or move to the left where they were asked where the smell is coming from most strongly. And boy, they did such a good job. And it was interesting that even though they could consistently turn to the gradient on the screen, indicating the degree of deviation because of the scent, they themselves could not say, I smell it stronger on the right, I smell it stronger on the left. It was much more basal that they would just sort of like instinctively turn towards the right or the left. They couldn't tell that.
Interesting.
And yeah, it was like actually really a fascinating experiment proving this. And then they went one step further, which was to say, well, is it an absolute value difference? Like if you have a concentration of 2 particles per million of vanilla smell versus 4 particles per million of vanilla smell. Is that the same thing as 2 to 4 versus 4 to 6 versus 6 to 8, parts per million, or is it a ratio? And it turns out that it's the concentration ratio that pulls you to right or left, independent of the absolute values of the smell.
Did they do appealing smells and also unpleasant smells to see if you turn towards the unpleasant smell or away from the unpleasant smell?
Oh, that's that would have been an awesome experiment to follow up. But no, they didn't. But I would actually, now that you're saying it, I'm like, yes.
I wonder if certain smells
should do that. No, they didn't do the Chris Gill sticky sweat sock smell test. They went for the pleasant vanilla smell test. But humans can navigate by smell. And it's not just like it's stronger as I move to the right. It is the left-right gradient that's actually pulling them to the right.
Very cool.
Totally useless, but fascinating to know.
All right. Well, that is the end of our program. If you got any feedback on this or any other episode, or you want to suggest a study or a topic for us to take on, you can tweet us at @PopHealthEX. You can tweet me at Prof. Matt Fox or Chris at ID.Gill. Or Jess, do you have a Twitter?
I do, but it is hence unused.
Is
so maybe
dormant.
I should jump in. It is dormant. So maybe by next episode, I'll get it up and going.
All right.
I haven't been a big Twitterer, but maybe I should become one.
All right. Well, you can do that, or you can find us at the Population Health Exchange website at www.pophealthex.org. We want to thank Leslie Talalian, Director of Lifelong Learning at the BU School of Public Health, for supporting the podcast, and Nick Guler for sound editing and having the most punchable face in the business. And I say that only because he has the biggest beard, not for any other reason. Thanks for joining us. We hope you enjoyed it, and we hope you'll download our next episode.